All right. So this module entails tracheostomies and kind of the same thing as we talked with the various airways previously. When do we use them? When don't we use them? What are they? How are they made? What are the parts and pieces to them? What kind of maintenance is required? And we're going to spend a little bit of time. One of the PEs for this, obviously, is tracheostomy care, so we'll spend some time on that. A good part of today is just going to be my brief lecture, and then moving on to a demonstration of trach care, and then it'll be open lab the rest of the day, so you guys can practice those 6 PEs, which are really 3. Okay? So let's talk about some of the terminology associated with this. Distinction between tracheotomy and tracheostomy. Otomy is the actual surgical procedure that goes through that creates an opening into the trachea. Once that opening is established, it's maintained by placement of a tracheostomy tube. The ostomy is the actual physical opening that is there. I'd say permanent, but it doesn't necessarily need to be in a lot of cases, actually. Once the tracheostomy tube is no longer necessary, the skin is allowed to close back up again. Okay. That tube itself is usually sutured into place, and those attachments are in the initial phase are left in place until the surgeon who did the tracheostomy comes back and remove them, usually within a week. So what makes up a trach tube? First of all, there's multiple brands that are out there. One we're going to focus on, because it's the equipment that we have the most of, is a Shiley tube. The other competitive brands are Portex and Bavona. Bavona is unique in that its cuff is not air-filled, the cuff is foam. So what ends up happening is, to place the tube in, you deflate the foam, you suck it out, and it collapses, and then once it's inside the airway, you allow it to re-expand. And the claim is that because that foam is expanding, you don't have a lot of problems with tracheal necrosis, because the pressure applied is atmospheric pressure. Sounds good in principle. Problem is, if you don't have the right size to start with, you got a leak. There's nothing you can do about it. So it really requires a very precise estimation of what the tracheal diameter is, so you put the right tube in the first place. If not, you get all kind of problems with leaks. Jackson, named for Chevalier Jackson, who was one of the physicians who I don't want to say revolutionized, but basically, the tracheostomy or tracheotomy procedure. He was the guy that was the surgeon that basically created it and created the first trach tubes and all the whole process. The unique thing about Jackson's are their metal. They're stainless steel. And because of that, they actually have a very low infection rate. They're unique in a couple other fashions, and we can pull out examples of them to show you. But one of the key parts is there's no 15 millimeter adapter attached resuscitation bag to or anything else. We can pull out in the lab. That's fine. People say, "Oh, you don't use those anymore." They're still out there. They're actually a nice airway for long-term management if we just need the airway in because I need to suction the patient out. Okay, but Shiley is the one that we'll focus on the most. So some of the components that are there, well, you have a pilot balloon just like you do on an endotracheal tube. That is attached to an inflation tube, which ultimately is attached to the cuff. There's a flange that is present. The newer flanges are much more pliable. The older, and you'll see some of the examples when we go into the lab. Some of the old style tubes, the flanges are just rigid plastic. And when we talk about having to place these tie strings to hold the tracheostomy tube in place, it's awful hard to manipulate them. So you'll see the difference when we go through them. Most tracheostomy tubes are dual cannula systems, where there's an outer cannula which is permanently left in place, and an inner cannula which is removable. It's removable so that you can go ahead and clean it and put a new one back in again. Now, when we talk about trachs, we'll pull out the trach box and show you. There's probably, I don't know, a dozen easily different types of tracheostomy tubes. We're going to focus on simply the reusable inner cannula with a dual cannula system. Okay, you can have just a single cannula tracheostomy tube where it's just one inner cannula, just like an endotracheal tube. Most of the ones you'll encounter, though, will be this dual cannula style. In the fall, blame Mary, she's going to go through a lot of the specialty tracheostomy tubes, things like fenestrated tubes, things like laryngectomy tubes, and I don't know what else she covers. There's a whole bunch of them that she kind of rounds out. The last part of this is the obturator. And the obturator only has a single purpose, and that is to dilate the skin as the tracheostomy tube is being placed. The obturator fits inside this inner cannula where the inner cannula normally would go, and it's allowed to go through and protrude out the end, making this kind of a rounded tip. And when we pull them out, we'll go ahead and show you. When every tracheostomy tube that you open up the kit or open up the packaging has an obturator designed for that tube. Okay? Because obviously these come in various sizes, which I'll talk about. But the obturator, basically what you do is you put your thumb over this end, that's a thumb, as you're inserting the trach so that it's causing the skin to part to place it in. Okay. Once the tracheostomy, once that opening, over time, the skin will begin to granulate and form kind of like a scar and remain as a permanent opening. It can eventually close, but basically, if you leave that opening long enough, it'll start to create its own skin, if you will, and the hole will become quasi-permanent. Okay, and a lot of patients, they have a tracheostomy for the rest of their life. Give you an example of somebody who would be somebody who had cancer of the larynx, has their larynx removed. There's no connection between their mouth and their trachea other than a tracheostomy that is present. They're always going to have that permanent stoma there. Okay. Am I making sense so far? I know it's early. Steve.
So the obturator is to go through the opening or to push through the trachea?
It's to push through the opening of the skin, to dilate the skin enough so that the tracheostomy tube can enter into the trachea. Once that's there, that obturator is no longer used.
So why is that goes inside the trachea?
Correct.
Like you said, so why is that even necessary if you already have
This end of the trach is very blunt, and that makes it a little bit more pliable for it to slide into the opening.
separate the tissue?
Separates the tissue. Otherwise, you would have to make a hole that is awful darn large that they don't want to.
Right, I've seen it done. I just never. I guess I never knew that there was a rounded tip.
Yep. Yep. Yes, Dana.
So where does where does the inner cannula go if the arbitrator is there?
It doesn't.
It doesn't?
Right. The obturator is only there to place the tube. Once the tube is placed, the obturator is removed, the inner cannula then is then put in.
Oh, okay.
Okay, and the key part is you always want to have that obturator somewhere proximal to the patient, because if that tube falls out at any point in time, you want to put it back in, you need the obturator to put it back in again. Make sense? I can kind of show you when we go into the lab what these structures look like a little bit better. Okay, let's talk about why do we use tracheostomies. Upper airway trauma, so if somebody perhaps has, like I said, a tumor in their larynx or their vocal cords or something, and they need to have that bypassed, we could do that by using a tracheostomy. Somebody who has poor cough, frequent needs for suctioning, and it's going to be a long-term process, we could go ahead and tracheotomize. We can perform a tracheotomy on them and put a tracheostomy tube in. Where we see it is with patients who have prolonged intubation. So if we know, and the time frame is always a moving target, most people say somewhere between 14 and 28 days. If we're ventilating that long, we probably need to put something other than an endotracheal tube in, because they're going to be a long-term management. So with those patients with Guillain-Barré, spinal cord injuries, that I know they're never going to be, or they're not going to come off the ventilator anytime soon, they'll have a trach in place. So when we go to camp, a lot of the kids who are chronically ventilated, they'll have a tracheostomy tube in place. Okay. The kids that have the CCHS, the congenital central hypoventilation syndrome, those kids have a permanent trach in place.
Are you still breathing pretty much normal for the upper?
Yeah, what they do is actually they cap off the trach during the day and they just use it at night. Kind of cool. And this is kind of just that process. In some of those cases, say the Guillain-Barré patient, they know they're going to be on a ventilator for an extended period of time. They're not going to wait the 14 days or 21 days or whatever to do the trach. They'll do it pretty much, right soon into the process, once they know it's going to be a prolonged intubation. But it's just one of those things that after a week or so, think, well, should we trach them? Should we not trach them? And in a way, admitting that you got to trach them means that I'm admitting that I'm not going to be able to get them off easily. And so a lot of times they're a little bit hesitant to do that. Yeah.
This might be stupid, but why does it matter how long they're on the ventilator? Just for
Well, you want to,
purposes, or?
the endotracheal tube, what's some of the problems with some of the disadvantages we talked about? Hard to communicate, can't feed them, pressure necrosis. Can you still have those with a tracheostomy? Absolutely. Tracheostomy tube cuff has the same complications as we'll find, but just a little bit easier to manage them. As far as insertion, there's multiple different ways to do it. Typically, it's done as a surgical procedure in the OR, where they're taken down for the tracheostomy. A thoracic or ENT surgeon will do the procedure, and the patient will come back. About, was it 10, 15 years ago, Nance? Percutaneous. Mm-hmm. It's relatively new, although now it's not so much new. But they started doing them at the patient's bedside inside the ICU. As far as a procedure, it's nasty. I don't know, to me at least.
It is, but it's less, the surgical site is a lot nicer than
Yes.
the scar of a surgical
Tracheostomy.
tracheostomy.
Yeah.
Feels nicer.
Yeah, basically what they do is they take dilators and basically just ram them in. Don't want to say that?
Sedated.
They are sedated. And they gradually increase the size of this opening. It's barbaric to watch in a way.
But it is getting better because they use less dilators.
Yes, yes.
First one to go.
And the tube's a little bit Structurally, it has a little bit of a difference, but for the most part, it's the same kind of tracheostomy tube that ends up going in. Good news is that it doesn't tie up an OR suite. That's one of the major reasons that they started doing them at the bedside. Also, the pulmonologist and intensivist can bill for the procedure rather than giving it to the surgeon. You know, it's always about who gets the money in the process. And then obviously we can do a tracheostomy at any point in time in the ER if need be. If somebody comes in with a situation where their airway is compromised and they can't intubate and they have to even have an emergency access to it, we can always do a trach at any point in time. And Mary will talk about percutaneous more so in the fall. Yes, Dana?
Wouldn't we do like, if it was an emergency situation, wouldn't you do like the cricoid?
You could, but if you have the equipment to do a permanent trach, that's tolerated a lot better than a cric will end up being.
Okay.
But sometimes you take what you can get.
Okay.
Chevalier Jackson, there you go, 1909. And basically the opening that is made there is between the second and third tracheal cartilages. And basically it's surgically exposed and opened. The opening that they actually do, this gives you the impression that it's this huge amount of neck. It's a small, relatively small incision, maybe 3 inches long, that is then dilated by pulling back on the skin, which is what they're showing there with the retractors. Is that the proper term there, Ken? Okay, good.
3 inches or 3 centimeters?
It's about that long. What is that? Maybe I'm exaggerating there. One of the key parts there is this, or a couple of things. One is these lateral stay sutures. These are the ones that are exposed after the procedure is performed, and you'll see these wires hanging out there. Those are the ones that the surgeon comes back in after about a week and removes, and basically don't touch them is the general rule there. The other thing I'm going to point out is the presence of the recurrent laryngeal nerve, and that's proximal to that. We'll find that one of the complications is damage to that nerve, which ends up causing problems with vocalization later on. And basically you can see the obturator here, how this is being done. The obturator is pushed in, creates a little bit of a softer point to place it into the trachea, and then it's just basically passed through that opening, second, third tracheal cartilage, and the tube is placed. When it's properly placed, you can see it's well below the vocal cords, so that phonation no longer is possible with the natural airway. Yes?
How does it breathe during the procedure?
Well, the endotracheal tube is left in place until that tracheostomy tube is slid in, and then one is slid in and one is slid out. They're just swapped out. You ask some of the most interesting questions. No, you're 100% right.
Well,
Never thought about it.
they're making that hole, means, you know, that obviously air is getting into that hole too, the whole time that they're sedated. They are sedated, as long as they're covered before they.
Right. All right, some of the other precautions and other things, I divide them into early, I think early, during, and late. The early ones obviously are just minor details like apnea and cardiac arrest and hemorrhage and losing their blood pressure. You know, big deal. There always is the potential to have some kind of an obstructive element present, be it secretions, being it tissue, being it clots that are formed from the bleeding. Not that it's a common problem, but a problem that does exist is the presence of air getting in to that space between the skin. So the presence of subcutaneous emphysema is a potential complication that occurs. Has Mary or anybody talked about subcutaneous emphysema? Okay. It can get pretty nasty in the process. We talked about recurrent laryngeal nerve damage, and the tracheoesophageal fistula is always going to end up being there. Aerophagia, which is the swallowing of air. along with that. Some of the late complications, where we'll see long-term wise, tracheal stenosis, where basically the trachea narrows at the point where the cuff is, typically. Tracheomalacia, where the trachea not so much narrows, but loses its rigidity, so the cartilage itself becomes soft, and both of those situations end up to, once the trachea tube is removed and the ostomy is allowed to close, leads to problems with the airway collapsing, and you'll have difficulty with you'll have an airflow obstruction that is just there because the trachea cannot support itself. They've actually gotten better now at putting in stents and other things to try and maintain the patency of that trachea. It's pretty interesting. There's that anamnian artery erosion that we talked about last time. See it far more often with a trach tube than you'll ever see it with an endotracheal tube. But again, if you have a trach tube that's pulsating, not a good sign, because that anamnian artery is a direct branch off the aorta, so it's going to erode and you'll bleed out in about a few minutes. And then there's some of the other commonplace ones that you would see as far as infections, both of the trachea itself and pneumonia is developing. A lot of times that difficulty cannulation, it's a slow process of trying to remove the tracheostomy tube. Sometimes we have to actually physically go down on sizing of the tracheostomy tube, smaller and smaller and smaller, until finally we can take it out. Sometimes we go to alternative types of tracheostomy tubes that allow for some spontaneous ventilation for periods of time during the day before we finally pull it out. And then, you got the scar in your neck that's always there. So, what's some of the advantages of these tubes? Well, we don't have the laryngeal problems. You got a tube going through the vocal cords. Over time, that's going to do some damage to the cords themselves, and you could actually have alterations in voice and or just a loss of voice secondary to that tube being in for a prolonged period of times. So trachs are wonderful because it eliminates that whole problem. Definitely easier to tolerate on the part of the patient than an endotracheal tube. Things like speech is possible. Things like feeding the patient orally is possible, where with an endotracheal tube it's not. If it comes out, it's actually quite easy to put back in. You just get the obturator and put it back in again. Even long-term wise, patients find them, you can wear a turtleneck or a sweater, cover up the opening in the process. It's less dead space because I'm removing, basically that amount of dead space. So ventilatory-wise, I have less problems weaning the patient. Elimination of main stem intubation, obviously. It's not that long of a tube inside the trachea. Easier to anchor and secure. And you can actually suction the left side a little bit easier just by positioning the patient differently. Downsides to them, a little more expensive, especially if you're taking the OR into account. You got a surgical procedure there. You got a permanent scar, never a nice thing. It's visible in most instances that when you see somebody who has had a tracheostomy performed, it's pretty obvious. Higher mortality than the simple endotracheal intubation. Anything else really that sticks out there? More infections. The presence of that stoma post removal of the tube, you still have problems where that until that fully closes up, you can't generate a really strong effective cough. So again, they run the risk of, even after removing, having to be wary of pneumonias. Same is true with Valsalva maneuvers, Not as much problems with, you do have a reduction in the sense of smell and therefore the sense of taste, but it's not as bad as an endotracheal tube necessarily being there. Okay. And again, we're bypassing normal conduction and we're losing communication, but it's a little bit easier than having that endotracheal tube in. All right, here's the weirdness that exists. Sizing of tracheostomy tubes are very confusing, and unlike endotracheal tubes, where I say I have a size 7.5 endotracheal tube, we all know that means 7.5 millimeters of internal diameter. Ain't like that on a trach tube. And there's not standardization across brands. Wonderful. Basically, you got to look at the box for what size tube it is. And therefore, we're going to need to look at the sizing of suction catheters very carefully. This is some of the various sizes. I don't expect you to know these, but you can see that they're actually sizing down to neonatal sizes, and then when they get down below 1, they go 0, 00, 000, etc. But you can see that the size that is present, say a size 6, has an inner diameter of 7 millimeters. And I believe that's for the Shiley. I think it varies for the Portex and the Bavona. So you got to physically look at the box that comes in to tell. But that's the downsize tube. These are called Jackson sizes, and don't know why he named them the way he did, but he did. And these other letters that are there, DCT, D, FEN, LPC, those are the Shiley's nomenclature for the different types of tubes. The dual cannula tracheostomy tube, the fenestrated tube, the low pressure cuff. You don't need to know the different names, but when we go through them, we'll show you what the standard tracheostomy tube that you'll need to worry about is. And here's some examples from Shiley, showing that the number 8 dual inner cannula, dual cannula system is an internal diameter of 7.6, an external diameter of 12.2. Makes it nice and easy, right? Nah. So, let's talk about some of the types involved. We're going to focus really on that very first one. It's called the low pressure cuff, and it has a reusable inner cannula. The DCT is something that is really nice, and when we go through trach care, if you encounter a place that has disposable inner cannulas, you will sing happy praises, and it's a whole lot easier. The reusable inner cannula, as the name implies, is that cannula is cleaned by someone and placed back into the patient at a later point in time. So there's usually 2 cannulas that are there that are swapped back and forth. One is always in the patient, the other one is soaking in a cleaning solution or is being prepped to be put back in at a later point in time. Disposable inner cannulas, as the name implies, you pull them out, throw them away, put a new one in. Boy, that sounds a whole lot easier. The downside, guess what? They're more expensive. If you factor in the time involved, it's probably a wash, but for a lot of places, that's an extra added cost that they don't want to eat. Okay. And the time of the individual that's spent, and when you go through your PE, you'll recognize this is a little bit of an involvement. Tubes can be cuffless or cuffed. Tubes, like I said, can be single cannula or multi-cannula. Tubes can have a special opening, and Mary will talk about this in the fall, but if this is my tracheostomy tube, here's my cuff. There's certain tubes that have a hole there, so when the inner cannula is removed, Here's my inner cannula. When I remove that, I now have an opening to use. It's called a fenestration. And with the cuff deflated, the patient can vocalize during the day, and if I want to put them back on the ventilator, all I do is put the inner cannula back in, reinflate the cuff, and I have a regular tracheostomy tube. It's kind of an interesting way to evaluate whether or not somebody can handle spontaneous ventilations on their own. There's tubes that have extra length here or here. So if I have somebody who has an extremely large neck, a standard trach tube may not have enough give in this distance between here and the outside. So I can get one with a longer curvature there. I can also get one that's got a longer curvature here. So if I create a tracheoesophageal fistula here, or have some tracheal malacia here, I just put a longer tube in, and now I can create a second one for, no. I could bypass that in the process. Jackson, we talked about foam cuff. We talked about Lands, Mary will talk about. And there's a whole slew of different types that are out there. We're just going to focus on the first two. So here's our reusable inner cannula. And you can see that you end up having a standard 15 millimeter adapter. This is just a clear inner cannula. The inner cannula, when properly placed, will be right at the very edge. And when you see how they fit in, you'll see that it fits right at that edge. So what it's doing is basically allowing us to take that out, clean it, and put an alternative one in the process. Okay. If you'll notice also on every tracheostomy tube, at least from Shiley, that we'll notice, it'll tell you what style of trach tube it is and what the size is. And when you look at them, you'll see what I'm talking about. So here's a disposable inner cannula. They're not interchangeable. They're two totally different products. So if the surgeon puts in a disposable inner cannula, guess what? We're going to be using disposable inner cannulas until they change that trach out. All right, securing of them is basically done with cloth ties, or what we're going to use in the lab is going to be a Velcro tie to make it easier. But you always want to have at least 1 to 2 finger breaths. You want to be able to put that in there. It shouldn't be so tight that you can't put 1 or 2 fingers in between the trach tie and the person's neck. Okay? Don't want to cut off their carotid blood flow in the process. And again, they're initially sutured in place, and after a week or so, those are taken out, and we use typically the Velcro trach ties, and we'll show you how they end up using them. And obviously, just like an endotracheal tube, now this would never happen in real life, that the patient would cough while you have that trach. Just cough the trach out. Oops. So these are what the Velcro ones look like. So here's my one part of the Velcro that attaches to this cloth part here. And you see them, you'll know what I end up talking about. There's various other things that are, this is kind of one, I don't know if you can kind of make it out there, but there's a ventilator circuit here, and these are just some extra little attachments on there to hold them into place. So when the patient coughs, they don't cough the ventilator circuit off their trach tube. Kind of prevents accidental disconnections. Okay, here's the important part. Cleaning. 5 steps to it. We're going to do some wound care. We're going to do some inner cannula cleaning and changing. We're going to do some changing of the trach ties themselves. And then finally, we're going to replace the dressing that was there initially. Okay? So these are the 5 steps you're going to end up following. Lots of stuff you end up needing to do this. Biggest portion are that we're going to have all the stuff we would normally have as far as suctioning equipment. But we're also going to have a bottle of sterile water or sterile saline, either or, a bottle of hydrogen peroxide, and the sink and the labs, by the way, magically also supply peroxide. Unlimited supply of hydrogen peroxide. You may need a topical antibiotic, and I'll talk about that. Need a spare tube, the same size, any kind of resuscitation equipment. Our syringe and pressures, manometers, stopcock system to measure cuff pressure. And then there's trach kits. And we have trach kits for each of you that you'll play with, and end up same as the suctioning, reusing again and again. Oh, and we have all kind of great stuff inside them. There is a sterile drape. There's a couple of basins, gauze, cotton swabs, cleaning brush, pipe cleaners, all kind of cool stuff to clean that inner cannula out, because they can get rather grungy. Just for informational purposes, by the way, in many institutions, the responsibility for tracheostomy care is done by the respiratory therapy staff. Some hospitals, RTs never touch them. Some hospitals, they're the primary. I'll be honest with you, I think we do a better job than a lot of nurses do.
But even if it is the nursing's responsibility, shame on us if we walk by one and it is gross and disgusting and
Agreed.
you leave it alone. Because that is so bad on our part. Because how about if that was one of your loved ones and you said, oh, that's the nurse's responsibility, and you walk by? Because I can't tell you how many of my coworkers walk by and say, that nurse just left that, and you did the exact same thing. Oh,
If we do it, do we document it?
yes.
Yeah.
Yes, we do not get paid for it at our place. That is not part of our
Yeah, but it's
revenue.
moral, you know.
Exactly. I cannot consciously leave a patient with secretions oozing out of his trach and say, nurse, you need to take care of that. I mean, come on, that's part of my responsibility too. It's just, but some of my coworkers do, and it just, you know, I just wanna go after somebody's throat.
Do you need to go through the chain of command,
No,
or just?
just do it.
It's part of my responsibility too. I mean, that's my patient also, because they're just as busy as we are. And some of these patients are just constantly oozing secretions, and she or he may have just done it 2 hours prior, and the patient just has so many secretions, it's just constantly oozing out. So I don't know whether it was just done 2 hours ago, just do it. Why am I gonna, tattle on somebody when I can do it just as good as somebody else and better? Just do
Well,
it.
just, if it's not your responsibility, somebody might say, well, she did it, and if something happened.
Just do it.
Okay,
Do it. It's-
just asking, I've worked in a situation like that before.
Oh, well, I mean, I don't, like I said, every institution is different. Document that you did it. If you see something, if there's a real bad infection,
Enough soapboxing.
there you go.
Okay, so we typically do this every 4 hours initially and then gradually taper that off. But it's really when necessary that you end up needing it. Some of those patients with long-term trach tubes in place will need it more frequently. But we're going to gather necessary equipment, verify that they don't, or that if they need to be suctioned, that we suction them first. Nothing is worse than getting a trach care done. He's all nice and pretty,
Oh,
and there's this big goob that just, oh man. So want to make sure you suction ahead of time, and that makes it a whole lot better. Two different scenarios that we're going to have. If a patient's on a ventilator, it's a little bit different of a process than if they're spontaneously breathing. For our purposes, for your PE, they'll all be on a trach collar so that it's not something where we're concerning ourselves with the ventilated patients. A little bit more of a need for having a quick swap when you have a patient who's being mechanically ventilated than a patient who's spontaneously. A lot of the patients you'll encounter that will not be on a ventilator who have a trach.
The other thing is you really do want to wear personal protective equipment. You want to make sure you have a face mask and a shield, because especially if they're on a trach collar, you're right in their face. All you need is that person to cough. And I can't tell you how many people have said, well, I'll just move. All you have to do, you just never know when they're gonna cough. At that particular moment when you have just turned your head to grab a piece of equipment and you turn back and they just coughed it right in your face. And I know
Even if you're standing at the end of the bed,
Oh, yeah,
They-
I've seen that one too. Yeah, they can shoot real good.
all right. So we go in, and the way this is set up is, if this is my tracheostomy tube, okay, and here's my flange, and here's my trach. There's trach ties here. There's also a specialized piece of gauze that looks like a pair of pants. Literally, it looks like this. And that's designed to fit in around the tracheostomy tube, okay? So those old dressings need to be replaced. So the first thing you want to do is gently loosen up the trach ties, the Velcro ties, so that you can manipulate around them, not fully disengaging them, because then what's going to happen is that tube potentially is going to move. So we go ahead and we remove the old dressings, dispose of them in an appropriate fashion because they are icky. We can verify the type of tube in place because that's written right on the tube itself. We'll take a look with this dressing gone. Now I want to evaluate that stoma and see how it looks. If it's very red or looks like it's swelling, that's where that bacterial ointment, the bacitracin, will come in as far as placing that on there just to kind of reduce the irritation. Yeah.
What would you do if you did feel the pulsation?
Holy moly, I would call my doc right away and say, I'm feeling a pulse on this trach when I'm doing my dressing change here. I'm,
Overinflate that balloon too.
yep.
Call the doc first, and then overinflate or put some pressure on the front end of that, the neck. Especially if you see any kind of oozing blood or anything.
That's just the scary one. Yeah.
The ointment, is that automatically ordered when somebody has a trach?
Yeah, it's just kind of a standard part of the process. Okay. So always want to have a spare trach at the bedside. Always want to have, if you have a disposable one, you want to have a disposable intercannula or cannulas at the bedside. If it is a reusable intercannula, there should be a spare one there to put in while I'm cleaning the other one. Okay. Go ahead and open up all of our equipment before we put on our sterile gloves. So we're going to go ahead and have the kit opened to the extent that I can access it. I want to have my water or saline open. I want to have my peroxide open. Go ahead and put on my sterile gloves, and now I have the creation of a sterile field. There actually is usually a drape on the inside of the kit that you can pull out and create that sterile field with. I'm going to designate the two basins. One's going to be for sterile water. One's going to be for my peroxide water mixture. And there in some cases there actually will be a third little basin there that you can leave empty at this juncture. Okay. This is the point at which then I need to designate clean, dirty. Okay. I'm going to go ahead and clean the surgical wound with a sterile technique, always cleaning away from the wound. So if this is my stoma that is there, I'm going to go ahead and clean in that direction. Okay. And if it's still sutured into place, it's a little bit trickier, but for our purposes with the PE, it's not going to be as much of a process. Use the cotton swab that is there to loosen debris. Sometimes the secretions become caked and crusty, and got to be careful that you remove them because there are obviously going to be potential problems with the skin if you don't. But using the cotton swab and the gauze with peroxide will actually help to clear some of that debris away. And then you'll want to go ahead and follow that up with a swab with water, so that you're not leaving the peroxide on the skin, because that can be a little bit irritating, as you know. And then just dry it off with a clean gauze. So if it's a disposable intercannula, life is good. I go ahead and swap that intercannula out, and job done. Not going to be your case for the PE though, because we're using reusable intercannulas. And we're going to go ahead and remove that intercannula, And the way the inner cannula works is it's slid into the outer cannula, and a little twist of the 15 millimeter adapter locks it into place. And when we get to the lab, you'll see what we're talking about. So unlocking it means I got to turn it the counterclockwise in the process and go ahead and remove the inner cannula from use. I'm going to go ahead and take that inner cannula I just took out and drop it into the peroxide mix that I have there. Go ahead.
But you do want to remember that it is a surgical wound. You want to hang on to that flange, especially on a fresh post-op, a fresh trig, because it hurts. You just sliced open somebody's neck, and by turning that thing, you're turning that whole trig. So you just picture a cut, and you're twisting something, it hurts. So you want to hang on to that flange as you're twisting that trig off, so you're not constantly playing with that whole trig site, okay?
Go ahead.
At this point, is it still a sterile procedure or both?
No, it definitely is a sterile procedure. One hand sterile, one hand non-sterile.
What are you removing the inner cannula with, non-sterile or sterile?
Non-sterile, because it's not sterile. It's been exposed there. And it's really it's not so much the 15 millimeter adapter, that's never going to be sterile in the case until we put a new one in, but then once you hook something back up to it, it's no longer sterile. It's the cannula itself that we want to maintain sterility on. Okay.
So when it says prepare for a ventilator patient versus spontaneous, is that because of the reusable versus the?
Well, it has to do with the fact that you have a whole lot more time to manipulate that and clean it and whatnot without having to worry about that outer cannula not having an inner cannula in. You can't do that with a ventilator patient. You can't ventilate the patient without that inner cannula in. So there actually is, make matters worse, a temporary inner cannula you can use for mechanically ventilated while you're cleaning the other one. And that's why we're not going to concern ourselves with during our PE. We're doing a spontaneously breathing patient who's on a trach mask. Yeah.
So you're holding the flange with what, because the non-sterile is unscrewing it. So what are you holding the flange with?
Where's your third hand?
You're actually, and we'll show you when we demo it, you actually are holding the flange with the fingers and turning it with your thumb and finger. It can be done. Okay, so then we're going to go ahead and if there's anything on the tube itself, cleaning that off. We're going to go ahead then and clean that inner cannula that I just took out in the peroxide solution using brushes and pipe cleaners and all kind of other stuff in the process. Going to rinse it in sterile water, shake off the excess, and you can put that one back in, but for our purposes, we'll have a spare one that's there from last time that we're going to swap out. So once that one has been taken out and dropped into the peroxide, you can go ahead and put the other one back in again and begin the process of cleaning the inner cannula. And again, this is what I was just talking about. It's a little bit more complex when you're dealing with a patient who's on a ventilator. But for our purposes, for this lab, we're not going to worry that much about it. And in all honesty, I don't think you'll encounter that over the summer anyways. Next step, once I got the inner cannula, the clean inner cannula back in, I can go ahead and change my trach ties. And this will be something that we'll go ahead and have you do. Remembering to keep it so it's not super, super tight. Can fit one or two fingers under the tie. And we're not going to use the twill tape. We'll show you what it's like, but most places use the Velcro ties. Then we want to go ahead and put the dressing in. One thing you don't want to do is you never want to use a standard gauze pad and cut it yourself. I don't know if you've ever looked at a gauze pad, but when you cut it, there's all kind of microfilaments that just fly all over the place, and they get into the wound, and it's just nasty. These tray kits are designed for that purpose, and they're actually manufactured in such a way so they're not They're not open. I'll have to say that. And there are some specialty dressings that you can use for some that are just really infected. For our purposes, we don't worry about that. Then I want to go ahead and assess my cuff pressure, and also making sure that the trach tube itself is positioned correctly. Remember, basically what I have is I have an opening here, and I have a tube coming down. That tube ideally sits in this fashion in relationship to the neck. There are problems that can happen because that trach tube can be tipped in this fashion, which means that this back end is eroding the tracheal wall. So you want to make sure that tracheostomy tube is properly positioned. There's some kids up at camp that have just over time because of neglect, because of I don't know what, just their trach is all contorted, and you know that the trachea on the inside is just a living mess that we're going to have to deal with later on. Yeah.
Do they have respiratory therapists working the dressage?
Yeah.
Oh, okay.
Yeah, absolutely. Yeah, from 8 p.m. to 8 a.m., there's a team of therapists and nurses that take care of the kids at night. During the day, there's a therapist and a nurse in the area where the kids are doing activities, and there's partners, usually 2 for every kid. And the partners don't have to be healthcare related.
So, why don't they have any at night?
Why don't they have what?
Respiratory therapists
They
working
do.
at night? They said,
No, nurses and therapists and docs at night.
oh, okay,
Yeah.
never mind,
Yeah.
sorry.
There's people assigned to care from during nighttime. And then finally, looking at the humidification needs. If you have an aerosol, there's enough water to last till the next stop. Is the FiO2 correct, et cetera, et cetera. For our purposes, we're going to make the assumption that they're all on a trach collar with a nebulizer, so it makes life a little bit easier. And I think it's on page 80 of your lab manual. Should be that whole process. So wound care, intercannula, tie change, dressing change, cuff and tube assessment.
Do you still want the cuff pressure to 20, 25?
Yep, same thing. Same thing. Dana.
So for the trach, we want it 4 to 6 centimeters above the carina, and then so